Hello, everyone. Thank you so much for being with us today. This is such an important discussion, and we have three scholars dedicated to our community who want to talk with us and teach us more about behavioral health and mental health services. So I think we're all in a student mode and hoping to learn and do better because we'll know more by the end of this hour. Welcome to our April forum, and today we're talking about mental versus behavioral health. If it sounds familiar, it's because our last forum in February, for those of you who attended, was the same topic, and we had such enthusiastic response to that one. We decided that we better pick up where we left off and keep going. If you weren't there, that's fine. You're going to get a lot out of the discussion today. We learned last time the terms behavioral health and mental health are often used interchangeably, but they don't always mean the same thing. We are going to dig a little deeper into the intricacies of mental health and behavior today. Before we get started, I just want to pause for a moment to say we are all very saddened by the loss of Dr. Wilbur Jordan. We just got that news today. Dr. Jordan was the head of our Oasis Clinic. He was a pioneer. He saved thousands and thousands of people's lives. It was really a wonderful thing to know him, to work with him, to be told off by him regularly about what we needed to be doing and doing more. So, Dr. Jordan, we send you our love in heaven. Now, let's turn to our first return guest, Dr. David Martins, who's a graduate of the University College Hospital in Ibadan in Nigeria. He completed his residency in internal medicine right here at CDU and holds a Master of Science degree in clinical research from UCLA. He's currently an associate professor of medicine at CDU and is a noted expert on hypertension. He served as medical director of THE Clinic when I was there, and he was a great leader and caregiver for patients in South LA. We're also joined once again by Dr. Denese Shervington, Chair of Psychiatry and Professor here at CDU. Dr. Shervington has testified before the United States Congress about childhood trauma and has authored several published papers addressing health disparities, social determinants of health, and resilience in underserved communities. Rounding out our panel is our own Dr. David Carlisle. He is the chief architect of CDU's growth and prosperity these years. He's a board-certified internal medicine specialist and served as director of the Office of Statewide Health Planning and Development in California for 11 years under 3 governors. And he's just been appointed to another statewide position that he'll tell us about, I hope. So thank you everybody on the audience for joining us. I'm going to start with some questions and time allowing, we will get to questions that you send in by email. Our attendees can ask their questions in the chat or tweet them with the hashtag CDU Community Forum, okay? CDU Community Forum. First, since not everyone watching was here for the first forum on this issue, Dr. Shervington, take a moment to define mental health and behavioral health so that we understand the difference going forward. And Dr. Carlisle, afterwards, would you give us a top-level highlight on how they differ? Dr. Shervington?
So I'm going to define mental health, and it's really our mental health is very much dependent on the extent to which we are getting our needs met. Our brain functions to interpret our internal organs and what they need to maintain homeostasis. It's also interpreting our environment the world around us, the sensations we're bringing in. And really the mind is just a reflection of these processes to help us understand how to survive and negotiate our world. So the extent to which we get our needs met is the extent to which we are mentally at ease. We know there are multiple factors that impact our mental health, starting from our relationships, in our homes, in our communities, and in society at large. And so I don't want to create static between behavioral health and mental health because it's used differently in medicine. Usually behavioral health is referring to conditions that result from certain behavioral choices we make. But this is still a function of the brain. The brain, the mind is interpreting our world, and it's reflected in the way we think about things, our cognition, how we feel about things, and how we behave and act. And so when we focus in on behaviors, we're just focusing on the actions we take in relationship to our world. The one concern I have as someone very involved in child mental health is that when we focus on behaviors in children, especially Black and brown children, when there is trauma that dysregulates the brain and creates hyperactivity, we tend to relegate our children to having behavioral problems and they're bad, versus thinking there are things in their environment that's creating trauma and they need a certain approach, a more compassionate approach to how we manage what they are showing us. Because children usually can't tell you what they feel, but they can show you how they feel. So I'm going to have our esteemed panelist, Dr. Carlisle, take it over as the internist.
Dr. Carlisle?
And I certainly defer to Dr. Shervington's expertise in this area. I'm a primary care internal medicine specialist. She's a psychiatrist and is well versed in this. I think that there are nuances between these two conditions. I totally agree. There may even be, I guess, characteristics or dispersions associated with either label. When people try to move away from the term mental health, it's often because of the feeling or the assertion or the assumption, that there's something wrong with your brain. You've got a brain problem, and by association, there's something wrong with you. But also the same can be said about behavioral health as well. There's almost an implicit statement. Well, you're just kind of acting wrong, or it's just really a matter of how you comport yourself. When in reality, these are really two sides of the same coin. It's the same issue. People should look at both conditions, both definitions, as a definition of illness, and something that may require various types of treatment, ranging from counseling or even before counseling, simply ranging from all the way from the need for support and engagement. And when we think about the childhood traumas, the ACEs, a lot of this causes trauma because young people have nowhere to turn when they experience a devastating situation, and that can develop into a full-blown trauma that can be with them for the rest of their lives, causing behavioral health issues. So these are, I think they really are the same, two sides of the same coin. And but I'm concerned about the way that they're used and the implications associated with them. I mean, quite frankly, we know that a very high percentage of every person will be faced with a behavioral health challenge or a mental health challenge at some point in their life. It's common to the point of being almost ubiquitous. And this could range from episodic depression related to an incident that somebody has experienced, or all the way to a full-blown psychiatric disorder, such as schizophrenia or bipolar disorder. The thing about all these conditions is that they can be very eminently treatable with the right type of healthcare system and the right type of access to that healthcare system. And so I think rather than even the labels, it's really the real question is how can we get people the care that they need when they need it? And that's the important thing, no matter where you are in those under those labels.
Thank you. Dr. Martins, I wonder, before I get to the request that you talk about common mental health disorders today and how they differ, Dr. Shervington's statement suggested that behavioral problems were sort of like the driver from your mind, how it negotiates reality for you, as opposed to mental health being more of a medical issue. Did I hear that correctly, or can you correct that if I didn't hear it properly?
No, I think what Dr. Shervington said, which I agree with, is that mental health is the way the mind works in negotiating reality. And the goal is to fulfill the needs of the body. And sometimes that can be behaviorally perceptible, and sometimes it is not. When we affect others in our search for what we need, in our own pursuit of happiness, and we affect others adversely, then we begin to attract labels like behavioral disorders, because we are breaching social norms and we're getting all these labels. So in the way I understand it from what Dr. Shervington said, the mind tracks needs within our body, negotiates reality to fulfill those needs. If those needs are met between what we considered societal norms in behavior, it goes unnoticed. Nobody notices it, right? But when we begin to traverse boundaries in societies and people perceive us unusual, then we begin to attract labels of behavioral disorders, And like Dr. Carlisle said, you see, what is interesting is that if you look in the DSM manual, right, there is a clear difference between mental illness and behavioral disorders, right? And what is interesting is that the 4th edition of the DSM manual, which is the book we all make this diagnosis from, when you look at the 5th edition, there are a lot of new additions recently that have been added to it. And I'm amazed at some of the things we have now come to put into the DSM manual and considered diseases, So in direct response to your question, Sylvia, examples of mental illnesses, like Dr. Carlisle said, are things like you and I know about: anxiety, depression, bipolar disorders, schizophrenia, and stuff like that. Now, when I was in training, the only behavioral disorders that I was familiar with was actually ADHD, right? Now, I wasn't familiar with much of anything else. But now we have this oppositional defiant disorder. We have intermittent explosive disorders. And let me tell you some of the symptoms of some of these disorders. Say, for instance, let's talk about oppositional defiant disorders. The child does not listen. He argues with adult. He interrupts. Going by that definition, we are all behaviorally ill people. That was all we all grew through. We all did that. We all argued with our parents. We all interrupted them, but they knocked that out of us by the time we are grown. What is unfortunate in our day and age is that our children are not being raised by us with strong recognition of what normal is. Right? And if you look in psychiatry, like Dr. Shervington, I hope we'll talk about, the most effective therapeutic strategy now in mental health and behavioral disorders is cognitive behavioral therapy, CBT. And the underlying principle of CBT is that the problems are coming from the way people are thinking, and it's coming from learned behavior. It's being reinforced by learned behavior. And the good news is that everybody with a behavioral disorder is capable of learning new ways of coping. Now, you tell me, how do we end up where we are raising children that don't recognize how to live as a human being with other human beings? And it bothers me seriously because there isn't enough family therapists for every family in the United States. We don't have enough psychiatrists for every single person in the group that we need. The community has to respond to this. For as long as we keep looking outside of ourselves for solution, these problems are going to persist and they're going to progress. I think we need to begin to look inwards. As a people, what are the values we want to embrace? As a people, how do we want our children to perceive themselves as human beings? What are the norms? And that is the whole idea behind this kindness, compassion thing that I've been talking about. Like, we cannot afford to be the degree of casual cruelty in our communities these days is alarming. We are not even recognizing it as a problem, and as a result, we're not responding to it.
Did you want to react to that, Dr. Carlisle? Your light went on, I don't know.
Oh, that was actually a mistake, but I fully agree with Dr. Martins, and I think that one thing that I will say is that from a policy standpoint, we are making great strides in our focus on this whole spectrum of conditions. And I would say that from a health policy standpoint, if there's any topic that is probably more broadly recognized as a priority, the only topic that I would say right now is that of COVID-19 and the pandemic. And what we're seeing now from a policy standpoint is an increased focus on the need for providers of all types to take care of patients, as Dr. Barnes was saying, psychiatrists and therapists, social workers, as well as the need to make sure that people have places to get care when they have behavioral or mental health disorders, and just a general recognition of the fact that these are conditions that, for the most part, people can be treated, and people don't have to be burdened down by the consequences of these conditions with the appropriate care settings. So there's been a very, I think, a significant reorientation of the healthcare system to emphasizing the importance of these conditions, when before, unfortunately, these are conditions that were often ignored. And as Dr. Martin said, you know, when we were training, it was ADHD that was the only behavioral condition we were aware of. But now the whole healthcare system, I think, is starting to embrace the significance of these conditions. The fact that they're so widespread, and the fact that treatment is so effective, or can be so effective.
Thank you. Dr. Shervington, didn't we used to do a lot of the supportive services on behavioral health issues in the church?
Yes, I think, you know,
And
our. Mhm.
it doesn't seem to be the source of young people getting the outline of what was acceptable and what was unacceptable behavior. But we're trying to talk about both categories as things that medicine is addressing. And I don't want to get outside of that, because you're all saying that behavioral health is part of our medical care focus. It needs to, as well as mental health. And I don't think that's commonly understood, to divide issues in that way. Can someone have good mental health but struggle with behavioral health, and vice versa? Dr. Shervington?
I think it depends on how we define the difference between the two. So I would say probably not, because if your behaviors are creating dysfunction in your life, then you're not going to feel good or think positively about what's happening in your life. But I want to get back to what you said about the medicalization of our mental well-being, which is kind of what you said. We know that having social supports is one of the best ways to be mentally healthy.
Mm.
As human beings, we cannot survive without each other. We learn to be human beings from each other. When a child is born, if it's not for the loving care and attention of caregivers who are going to suspend their needs, you know, when you want to be sleeping at night, but your baby's crying, you have to get up. So we are very social organs. And I think as we have evolved, we've forgotten how much we need each other, how much we depend on each other. And so, yes, there were places in the Black experience, the church, certain social aid and pleasure clubs that really helped us to be well, helped us to take care of ourselves and to have a community that supported us. And I think we're going to have to try and go back there a little bit more, because everyone has said that clinicians are just a small part of the solution about us being well as a society.
Mm-hmm. Even though you carry such a heavy load.
Mm-hmm.
Dr. Carlisle, how do culture and ethnicity influence mental health and behavioral health? Another small question.
Well, there's been an increasing amount of emerging research on this. And I'm not an expert in this area at all, but there are individuals who've actually researched this pretty intensively. And I'll just mention throughout one name. So Dr. Kamara Jones at Morehouse School of Medicine has been active in this area, but there are many others. And what we're seeing is that when we can actually measure stress through things like cortisol levels, we see that African Americans experience and react to a lot of stress that we encounter in our lives, and this is chronic stress, and we're starting to see that this chronic stress has physiologic impacts upon organ function and preservation of organ function, for example. And so we're starting to see biological evidence that this is true. We talk about centromeres genetically and things like this. All these, I mean, the evidence seems to be pointing in the direction that most people would expect it to be pointing, which is that that because of the environment that we're in, African Americans experience stress, and this has impacted the body's physiology. And of course, that stress manifests itself in behavioral manifestations, and ultimately long-term in other manifestations as well. So this is kind of a new area, but the research is tending to basically underscore, I think, people's impressions that that people have had for decades. And it's an example of how the external environment can impact one's bodily environment and function.
Thank you. Dr. Martins, actually, Dr. Shervington, is the field of mental health now helping us to understand the difference between the levels of stress that Dr. Carlisle is talking about in different communities? What the level of stress as a Black person versus the level of stress as a new immigrant facing the challenges of entering the United States. Are we looking at that? Are we differentiating that? Are we helping diverse communities understand your families, your community is facing X, another community is facing Y? Are we doing that? Is the field following that?
Yeah, we certainly have the biologic evidence of the impact of stress, usually represented by higher levels of cortisol or low, depending on where it is, on the body. So the damage to organs inside the body, genetic challenges, epigenetic changes, telomere shortening. So we have the biologic evidence. We also know that when mothers are pregnant, if they have a high level of stress, the most recent disaster we've seen is with Sandy, Hurricane Sandy, that the children born offspring during pregnancy where a mother was on high levels of stress, that they're more likely, the children, the offspring, are more likely to have anxiety disorders and depression. Certainly I can speak about what happened in New Orleans post-Katrina.
Yeah.
High levels, we didn't study that, but all the other studies of disasters, the Holocaust, 9/11, show the impact of large levels of stress on the body. We also know there is the work that's done by Arlene Geronimus around weathering, that in African Americans, we are more likely to show aging, which then can result in, when we think about infant mortality and low birth weight, all of these cumulative impacts of stress on our bodies. We know that. The thing is, what are we doing about it? And that's the challenge for a university like ours, where this is our primary mission to address these conditions, that we have to look at policies that will address the impact of usually these environmental factors. Natural disasters, that's one thing, but some racism and poverty, they grind our bodies down too, and we know about the impact of toxic stress on the brains of young children that results in some of these disorders. And yeah, so I could go on. I'm very much anti the diagnosis of ADHD unless we've done a trauma investigation, assessment, to make sure that what we're seeing being expressed as poor attention and hyperactivity is not due to the brain, the hypothalamic pituitary axis. We know the organ systems in the brain that become dysregulated with stress. And why that's important, when we diagnose a child with ADHD, we tend to, one, we treat them with certain drugs that can become later in life addictive, and we don't give them the talking therapy that they need to be able to understand the traumas that they're experiencing. So again, in my work, after a major disaster, where there was a significant increase in writing prescriptions for drugs to treat Black children diagnosed with ADHD in the state of Louisiana, I know in my work, I went back and got the stories of these kids and their families, and they were suffering with poverty, suffering with things happening in their households, violence in their communities. Those are things we can change and that we shouldn't medicalize.
Dr. Barnes, in the immigrant community, are the things that she's describing prevalent but more unseen because of the struggles to acclimate to a new environment and find housing and work, so on? Is there an invisible mental health need in new immigrant populations that we're not trying to take care of?
Yes, there is, but Dr. Shervington did a lot of work on resilience. And part of weathering is having good resilience. Immigrants populations, does not matter where they're from, tend to come in a little bit more resilient because they are living usually much worse social environment for a better social environment. And because they have coped in those other environments, they come in here a little bit more resilient. But that resilience is lost over a couple of generations, right? As they acclimatize and their perspectives begin to change. You see, the themes, like, I just want to say something to us. Children come to us as blank slates. We mold their perspectives by our culture, the examples we set around them, right? And then when they begin to encounter the world themselves, they use us and the behavioral pattern they've learned from us as their reference point all the time, right? And if, to the extent that those behaviors conform to standards in the community and in society, they'll be just fine. And to the extent that those behaviors do not conform, they will be that much more uncomfortable. You see, my fear is that it is good that we oppose the labeling of children, right? With all these crazy diagnoses, intermittent explosive disorder, conduct disorder, oppositional defiant disorder. Because once you label the child that, then everybody begin to look at the child for that particular behavior pattern, right? And that attention that the kid never got is going to get now by behaving the way he's been expected to behave. And then we turn around and then penalize them again for doing things. How can there be sin where there was no law? You see, we talk about behavioral disorders and mental health. I think what is more important for our community is let us begin to define what normal mind is for ourselves. What is normal behavior? Let our children know, because there isn't enough of modeling of that, right? We need to define for ourselves, because, in America, we're in this cultural melting pot, and we have a lot of moral ambivalence bubbling up from this. At the end of the day, our children and our community, we're going to live and die by our choices. And we need to train children that can choose to live and not be victims of circumstances.
Dr. Carlisle, does stigma play a role in families seeking help for these problems?
Oh, absolutely. This is one of the major challenges that I think we face in working in this environment. I think it's well recognized that that stigma exists among various different types of communities with regard to these challenges, and whole groups of people are maybe from backgrounds where these conditions are just not recognized, and so it's often difficult to self-identify as having a challenge when there's not been a historic recognition that challenges in the behavioral and mental health realm exist. There are also environments where having a condition in this area is considered a sign of weakness versus toughness, and you're not supposed to seek care. You are kind of deficient if you do, and many patients face these stigmas as part of their as part of their treatment or their care situation, and fail to avail themselves of all types of services, even counseling. And of course, there's the perception of the strong individual who's able to sustain themselves and make it through any challenge. But that strong individual may often be the type of individual who's not even willing to talk about, even with a friend, a challenge that they may have. So this is an important component of this entire spectrum of conditions that is present throughout conditions. Individuals with bipolar disorders or schizophrenia who don't take their medications, for example, there's a stigma associated with taking medications that they encounter. So stigmatization is an important part of this entire spectrum of conditions, and it's a barrier to care.
Do you think maybe at CDU we could have a videoed conversation between our students talking about these issues to normalize the fact that there are stressors, there are problems, and there is care available, and it's okay to seek it? I know just being a student is so stressful so often, because not only is the subject difficult or the subjects are difficult, but money is hard. Finding a good place to live is hard. There's so many challenges that a student has independent of these psychological challenges. But I don't think that we invite them to normalize it in the same way we normalize sexual activity and said, you know, you need to use protection, you need to seek care if you have condition. And young people got it, and they talked easily with one another about it, but they don't talk easily with one another about mental health and what you do if you're having these stressors. Dr. Shervington, am I wrong? Is there a body of conversation that goes on among young people or among seniors in terms of what do you do if you're having these feelings?
I think not as much as we would like to. The recent data that's coming out of the CDC, the Centers for Disease Control, shows a significant increase in youth mental health disorders, a significant increase, which is very bothersome, in suicide in Black and brown children, the age group between 10 and 14. So we're not doing enough. And COVID just made everything worse. It was beginning to worsen. And as of 2021, we have a crisis in these United States around youth and mental health. Much of it could be resolved by what we're doing here. We have to be careful that we don't medicalize suffering in the world and begin to give kids Xanax and Prozac. A lot of it can be resolved with kids feeling that they're being heard, they're being listened to, that we're there as older folks, helping them to understand how to negotiate their world. I hear Dr. Martin is making a lot of reference to the norms that we create. And I just want to say that, you know, one of the most vulnerable and important times in our life as human beings is between 0 and 3 years old. And I remember being in Zimbabwe, and every little baby was tied. When I went out to the more rural areas, babies were tied to their mother's back. We know that when a child feels the safety and security and attachment to caregivers, their mental well-being is that much better. So how are we supporting maternal child health policies? That's something we can do. And perhaps we need to start thinking to advocate as a psychiatrist and very much in the space of child and adolescent psychiatry. I feel it's my role to be out there and say, let's try to do what Canada does, 18 months of parental leave. Children, most mental health conditions begin before age 5, the vulnerability to develop mental health conditions, and a lot of it can be managed if we allow for healthy, positive attachment and access to the resources that families need to get basic needs met. And so I don't want to over-medicalize mental health, but because I know that if we were more caring and compassionate as a society, we would see much less dysregulation amongst our children and adults as they grow up.
This is a question for Dr. Carlisle and Dr. Martin. With its ability to create or amplify body issues, impact self-esteem, and generate anxiety, what role is social media playing in the ongoing mental health issue in America? You want to start, Dr. Martins? Is social media, is that our enemy?
Oh no, because you see, social media have these persons called influencers, right? And these influencers, believe it or not, they are influencing the way our kids are thinking. And you know what is interesting? I see it, the social media has a standard for behavior. And when people go out of those parameters, they are often slam dunked and shamed on the media, right? So people are more careful in social media in what they say and how they say things, because the consequences are very immediate. I just think that as a community, we can be as responsive to negativities and toxicities in our environment as we are on social media. Because if a lot of the things attract similar consequences in the community as they do on social media, we'll be a better community.
I'm not sure I understand that.
Okay.
How would that play out more effectively?
Let me give you an example. There was somebody that was making negative comment about someone else's appearance on social media. And immediately there was a backlash that you don't say that to people, you don't talk to people like that. Okay. And immediately an apology was rendered.
Okay.
It was immediate. So what I'm saying to you is that on social media, because of the depth and the breadth of it, the collective expectation of human interaction in social media has a standard. And if you go past it or you go out of the expectation, the repercussion is immediate. I'm saying that we are not as responsive to toxicity and negativity in our communities as they are on social media.
Oh.
If we are as responsive to those things in the community and those early ages, like Dr. Shervington said, we'll have a lot less of these mental and behavioral disorders to deal with.
Dr. Carlisle, are we a body which can respond in the ways that Dr. Martins is describing? Are we so outside what he's describing in social media? It's a whole different world and a whole different age group, and we're not in it. I don't even know what you're talking about. It's so far beyond my age.
I was going to say, you were saying we, Sylvia. You meant you and me. I would agree with you.
But I think what he's suggesting is that there's an ethic among young people that you can violate that ethic. But I'm also aware that there is among young people such a norm that if you go outside that norm, you get criticized for that, you know, the way you dress or the way you talk or who your friends are. And so I would love it to be more of the positive that you're talking about, but I'm surprised to hear that reflection, because I don't, well, of course I don't watch young people's programs, but but I think they're highly sensitive about who they are and how they present themselves, and to be shamed, as he's describing, by someone calling up saying, you did something wrong there, don't do that, don't say that about somebody, would be devastating to that speaker, I think. And then friendships would be at stake with that young person. But you're suggesting, what I'm taking from it positively, is that young people can help each other with these issues and model a different kind of sensitivity. Is that what you're saying, Dr. Shervington? Do you think they have that power? Do they exercise that power? Or do they just role model?
I think it goes both ways. I think there is, you know, with all technologies, there is the way in which they can serve us as a society, which is marvelous in the examples that, the example Dr. Martins gave. There's the other side where, you know, young people are measuring their self-esteem based on the amount of likes or lack of likes that they get. So again, we have work to do. Again, the beginning development of one's self-esteem happens in those first 3 years, when a caregiver makes a child believe that they're special in the world, even though later on you find out you're not. But it's really important in those first 3 years, because you're totally dependent on another human being to take care of you. So if we can build that strong sense of self in those early years, then the function that Dr. Martins described, where it could actually help us to develop a more ethical way of being with each other, that would be great.
Dr. Carlisle, in the previous forum, each of you mentioned what you saw as some of the biggest challenges in communicating the difference and importance of mental and behavioral health in communities like South LA. What can we as community members do to offer support and ultimately combat these challenges? We don't all have PhDs, we don't all have MDs. We just live here, worry about this, don't know exactly what role we're supposed to take in addressing these issues.
Well, I want to agree with one of Dr. Shervington's points earlier, right at the beginning of this discussion, which was that our communities do have historic mechanisms to provide support, and they exist. And just for example, things like barbershops and beauty salons. Those are increasingly recognized venues for providing support, counseling, advice that are kind of intrinsic parts of the African American community. And so those are just examples, but a lot of it has to do with just simply the way community members interact with each other, recognizing it could be a nod on the street, a smile, that type of thing that can provide just a little bit of encouragement or support to somebody when they're kind of feeling a little bit down and out. A simple hello, a simple acknowledgement that the person that you're talking to is a peer. They may not look like a peer necessarily. You may not totally regard them as a peer, but they are a peer. And communications like that are very beneficial. I think because of the external pressures on much of the African American and Latinx communities, our communities have developed internal coping mechanisms that are informal, but they do exist. And I think they are sources of strength within communities.
I think we have an opportunity listening to this conversation just to be more helpful to one another in our CDU community. Having listened to what you have all described so well, I remember there was a function and there were tables and there was a young person sitting alone. And I just sat down beside her and started to talk. And she said, "I'm so glad that you came in to sit and talk with me because I was feeling so alone." So you don't know where a little touch from you, a little awareness of people around you might really help with the serious challenges that people are having emotionally with their mental health, even with behavioral health in their families. So there's so much more that we need to do. And I think this has been a rich discussion of the complexity of it, the opportunities, the different kinds of supports that actually are available. But I think we just need to run up the flag to say mental health is important and everybody needs to be working on it wherever they are, whoever they're interacting with. They need to be aware of it. They need to learn more about the difference that you've described between mental health and behavioral health, and be ambassadors for more well-being among the people that we care about. So I want to thank each of you for this discussion. I want to give each of you a last word of what you'd like to share, particularly with our students who are listening to this today, to encourage them. Can you start, Dr. Martins?
I mean, I am a firm believer in kindness. I think we can be kinder to ourselves. And there are two types of kindness. When kindness is motivated by love, it is called loving kindness. And when it is motivated by suffering of others, it is called compassion. It is the same kindness. We just need to be nicer to ourselves, be more sensitive, say hi to ourselves more, share things with ourselves, tolerate ourselves a little better, rather than labeling ourselves with all these toxic labels like intermittent explosive disorder, oppositional defiant disorders, these things that tend to command the negativity and spread negativity among ourselves. I think that will go a long way and create a better environment where we can all feel safe and secure in our place.
Dr. Martins? I mean, Dr. Carlisle, what would you leave the students and listeners with today?
Yeah, I'd certainly agree with those comments. I mean, one important message for everyone, regardless of exactly what the circumstances you may be facing are, is to know that you're not alone. And that's an important realization to make because of the isolation that often is associated with these circumstances. At CDU, for the past 2 years now, we've brought social services and behavioral health services onto our campus. Those services are actually pretty heavily utilized, but they're utilized because of the stress of the educational process. We're in an area, health professions, where stress is something that is faced by our students. There's the fear of failure. And we're going to ratchet things up to another level as we open our new medical school, where stress is inherent to a certain extent within medical education. We know it's there, and we have mechanisms in place to embrace our students. But I just want to make sure, whether you're a student, a staff member, a community member, as you're facing these circumstances, really know that you're not alone. And there are individuals that are out there for you who want to be able to work with you to address your challenges.
Dr. Shervington, let me ask you for the last word. We have a question from Jasmine, who's an MS/BMS student here at CDU. And she says, how can aspiring physicians and medical students be mental health advocates for at-risk groups in all communities?
Well, there are community organizations that focus on mental health and well-being, and you can ask that student to connect. It depends on exactly what kind of advocacy she wants to be engaged in. I'm happy to do some more connections specifically. I think perhaps going back to the issue of stigma, the best advocacy is for us to have these conversations, to know that our mental functioning is a part of who we are. It's a part of our biology. It's a part of how we perceive our world around us. There's nothing stigmatizing about our minds, no more stigmatizing than our lungs or pancreas. So finally, I just want to remind myself and all of us that we live in relationship to each other. We can't survive without each other. So kind of a lot of what Dr. Martins is saying, love and compassion is the way forward. Our children need us, they're suffering, or they're perceiving that they're suffering. COVID was very difficult to navigate for adults, much less children. So we probably need to smile a little bit more with a child who doesn't belong to us, because ultimately everyone belongs to each other.
Well, thank you all so much. This has been such a rich conversation, and I'm sure that staff is going to say we need to come back again and talk about mental health challenges, because it isn't discussed enough, and it's so front and center in our effort to get back to normal and to live meaningful lives with our associates, our fellow students, our loved ones. So thank you for the compassion that you all show for people who are facing these challenges. And thank you for your time and your insight and experience today. It's been a rich discussion.
Thank you.